Assalamualaikum and good evening, everyone. Am I audible? First, tell me properly. My voice is clear.
Walaikum salam. Yes, sir.
So, thank you. We are today about to complete the whole brainstem, all surgical approaches, safe entry zones, and anatomy. So, this is the last topic that is about the midbrain. So, this is actually the midbrain. The midbrain has two surfaces as like that of pons and medulla oblongata. So the anterior surface and the posterior surface. This is the anterior surface. Later on, we'll see the posterior surface. So when we see actually the demarcation of midbrain, it has the quite interesting and important landmarks and structures. We should know very well this one. So this is the junction between the pons and midbrain. That is called the pontomesencephalic fissure. And this is the area, that limit of the midbrain, this one. Okay. This is the limit of the midbrain. This is. So in circle, the yellowish circle inside it is the midbrain. It has a lot of limitations. Posteriorly, there is a postomesencephalic fissure. Anteriorly, there is an optic apparatus is there. This is optic chiasm. Okay, this is optic radiations. You can see very well easily anteriorly with the optic nerves. So it has an excellent and important relations. Later on, we will also discuss these relations, that how it is important. When we see this anterior surface, most likely it is made up of cerebral peduncle. I am saying cerebral peduncle, not the cerebellar peduncle. Okay, there is a difference. So be clear about it. I am saying that the cerebral peduncle. So you can see these two from here to here. This is one cerebral peduncle and this is another one, left and right. So this is cerebral peduncle, not the cerebellar. Okay. So this cerebral peduncle, the anterior surface is mainly made up of these two cerebral peduncles. Okay. These cerebral peduncles are for the tracts, ascending and descending tracts. That's why from the cortex towards the cortex and from the top cortex, the cats ascend and descend through these peduncles. That's why it is called the cerebral peduncle, the connection with the higher mental cortex, or you can say the cerebrum. So in between these two peduncle, there is fossa. You can see clearly this is a fossa. I am changing my color of this one. Can you see this one? This is a fossa, this one, and this whole is a fossa actually. Okay. So in this between two peduncle, there is a fossa. So name it. Yes, please. The fossa in between these two peduncle.
Interpeduncular fossa.
Interpeduncular fossa. The fossa in between these two peduncle, it's called the interpeduncular fossa. What is importance of this fossa, interpeduncular fossa? Yes, anyone? So now we can see.
Interpeduncular
Yes. Yes.
Interpeduncular cistern, sir.
Interpeduncular cistern. Excellent. Another importance?
It's where the oculomotor nerve emanates from.
Excellent. Oculomotor nerve is there. Look at here. This is oculomotor nerve. Okay. Another importance? Another surgical importance. Anyone?
Sir, if there is any communication between the interpeduncular cistern and the chiasmatic cistern, it means the membrane of Liliequist, it ruptures and it occurs in the pretruncal subarachnoid hemorrhage.
Excellent. Excellent. Anything else? So it means while we are doing the ETV, endoscopic third ventriculostomy, this interpeduncular fossa has a great importance. Look at here, Actually, it is a midbrain, but its surface has some important structures of diencephalon as well. There is also some structure of the related to the pituitary as well. Can you appreciate? Posteriorly, this is what? This is the posterior perforative substance. I have circled this one, this triangular. This is the posterior perforative substance. Just anterior to this one, these two surrounding circular bodies, these are called? Yes?
Mammillary bodies.
Mammillary bodies. Excellent. This is the mandibular. Just anterior to this one, it is?
Infundibulum.
Infundibulum. Just anterior to this one, what is this one? Yes. Infundibulum, here will be the pituitary stalk, and you can say the tuber cinereum. So look at here, this is not only the midbrain anterior surface, actually it has a good surface that very important relation with the endoscopic third ventriculostomy. So there's a posterior perforative substance just anterior to it. There are two mammillary bodies, and this is infundibulum, tuber cinereum, okay? And here we have pituitary stalk, and later on we can see the pituitary. Okay, just posterior to the posterior perforative substance, at the mid of this one, there is a third nerve origin. Look at here. This is third nerve origin. Okay, this is third nerve, oculomotor. Okay, that's why it's important that when we are doing endoscopic third ventriculostomy, this is a chance of transient deficit of third nerve, transient injury to the third nerve, because we are actually near to the interpedunclar fossa. So just anterior to this one, there is the optic apparatus, this is the optic chiasm, optic radiations. Just anterior to optic radiations, can you see this area? This area, please. What is this one? Yes. Anyone? Let's visit the base of the skull. So
Anterior perforating substance, since no one else is saying.
Anterior perforative substance. Thank you, Dr. Kamal. So this is anterior perforative substance. Just anterior to this one, at the medial side, you can appreciate the olfactory nerve. This is olfactory nerve and olfactory bulb. Just lateral to this one, look at here. This is the frontal lobe. This whole is the frontal lobe. And this is which lobe? This is which lobe? Yes. This is temporal lobe. This is frontal lobe, and this is temporal. So this is anterior perforative substance. This is the most part of important structure. Later on, we will see here. You can see this fissure is there. So what is this fissure? Yes, please.
So Sylvian fissure.
Salvian fissure, excellent. So we are at the basal part of the salvian fissure as well. So how it is correlated, the base of this anatomy, all anatomy, especially the midbrain. So it's very important. So this is the basal part of the salvian fissure. Medially, we have the anterior perforative substance. Just anterior to this one, there is the olfactory bulb, the optic nerve. Just posterior lateral to this one, the optic radiation. Posterior medial to this one. Medial to this one, there is the optic chiasm and optic nerve that has been cut down, and that is the peduncle. So anyone is clear? Any question in that case? No?
Yes, I have a question. What is the clinical relevance of the anterior perforating substance?
What is?
The surgical importance of the anterior perforating substance that you just highlighted. Thank you.
I highlighted this, the relations, only the relation of this one, that this is the in anterior to just anterior optic nerve radiation, there is a anterior perforative substance. Yes, there is a surgical importance of anterior perforative substance. When we will do the surgical dissection of salvian fissure, and when we do the approach towards the medial parts of you can say, the temporal lobe, like the amygdala and hippocampus. So that's one, it's very important landmark. Okay, so when we discuss in this one, this will be, we can address this one when we dissect the Salvian fissure. This is the landmark of this one. So we have to be careful about it, that we should not damage this one, and just medial to this one posteriorly, there will be the amygdala and hippocampus. Okay. So when we say that is the posterior surface, anterior surface is mostly it was called as the cerebral peduncle surface. When we see the posterior surface actually it is called the tactile plate. So this is the posterior surface. This is the posterior surface. Okay, this is the posterior surface of midbrain. It has also the good relations as well. We know we will try to understand it. Okay, so tactile plate, it's called the tactile plate. It has some important structures. There is circular structures, two above and two below. What we call it?
Superior and
Yes.
colliculi?
Superior colliculus and inferior colliculi, superior colliculi, inferior colliculi, right and left. Just above to this one, there's a one structure midline circular. What is this one?
Pineal gland?
The pineal gland.
This is pineal gland. Excellent. Okay. Behind this one, part of here, at the most important structures there, that in between the sulcus area of pontomesencephalic circle, this is the nerve. Which nerve this one?
Trochlear nerve, sir.
This is trochlear nerve. Okay, this is trochlear nerve. Trochlear nerve is the only nerve in the brain stem, you can say, that rise from the dorsal surface. It is the only nerve which arise from the dorsal surface, posterior surface. All other nerves mostly they arise from the anterior surface or the anterolateral surface. But the trochlear nerve is the only nerve that get the region from the posterior surface, then come anteriorly. Okay, so these are the important structures in the posterior surface. But look at here that the superior colliculus have some other, there are other relation structures as well. So this is superior colliculus. That is a band also. You can see this band, this one, and inferior colliculus also has the band of this one. Look at here. So what is this band?
That's the superior brachium.
Who is there?
The superior brachium
Yes,
leading
you're
to the
right.
lateral geniculate body.
Excellent. Who is there with me?
Dr. Shafar.
Dr. Shafar, excellent. Thank you. So this is superior colliculus. So look at here, this band is there that going laterally, so connecting this area. Can you see? There is also an structure there. So the superior colliculus, superior brachium, it is connected to the,
Lateral
to which one? What?
geniculate body.
Excellent. This is lateral geniculate body. Okay. This is lateral geniculate body. This is lateral geniculate body, and this is optic radiation that from coming to anteriorly at posteriorly, it will also connect here. This is the lateral geniculate body. Superior colliculus, superior brachium, lateral geniculate body. So now name this one. This is the inferior colliculus. What about this one?
The inferior brachium.
Inferior brachium. And what about this one?
The medial geniculate body.
Medial geniculate body. And just anterior to this one? Anterior to this one? There will be the cochlear nerve. So look at here, these structures, the superior colliculus, superior brachium, it connected with the lateral geniculate body because it's the visual, it helps in the vision. Okay. The inferior geniculate body, inferior brachium connected with the medial geniculate body. Okay. Up to here, it's clear. So now we have another relations. What is this structure? Yes. Yes, please. It is
So
very
thalamus.
important to excellent thalamus. Excellent, Dr. Sana. Thank you. So this is thalamus. So this is the thalamus. This is section of the thalamus, part of the thalamus that we call the pulvinar. So this is the pulvinar part of the thalamus. Okay. Superiorly, that's why it is connected with the diencephalon midbrain. It is very important anatomy. Why? Because when we are going surgically approaching this area, we have to be careful to in dealing these all structures because this very near structure and interconnected this one. Okay, this is the posterior surface and important relations in the superior, lateral, and the medial relations.
Dr. Itzaz has been on break. I think he has had some interruption. It's not that you cannot hear. So he's back.
So I'm here. Thank you. There is some emergency in a case, surgical case, so that's why. Thank you, and sorry for it. So this is about the posterior surface and relations of the posterior surface to different structures. Any question up to here? No? It's clear? All clear?
Yes, sir, it's clear.
And I tried my best to make it more simple and simple way. I tried to explain this all things in a simpler way. Then why are you so silent? When you become so silent and quiet, it makes me surprised. It's clear, yes? Dr.
Yes, sir,
Mustafa,
clear.
Yes,
Yes, sir.
that's good.
Dr. Shafar, and other people, it's clear?
Yes,
Yes,
sir,
sir.
it's clear.
Okay. So we have completed the topographic anatomy of midbrain. So let's see. This is another view. This is the endoscopic view. You can appreciate in a very good way. That is the cerebral peduncle, the pineal gland, superior colliculus, inferior colliculus. That is the nerve area. That is about, you can say, the which nerve? It is trochlear or oculomotor nerve?
Trochlear.
It's trochlear because the dorsal surface, so trochlear nerve will be there. Okay. So when we see the transverse section of the midbrain, we divide it into three parts. The transverse section will be divided into three parts. There are some landmarks are there. So this is superior colliculus. This is the dorsal surface. This is the ventral surface, anterior area. This is the cerebral peduncle, and this is cerebral peduncle. Okay, you have to be clear about it. This in between this cerebral peduncle, this area, triangular area, is the interpeduncular fossa. So, and this is superior, this is inferior colliculus area. Okay, so we have a transverse section. So now we divide this transverse section into three compartments. One compartment just posterior to the cerebral aqueduct. This is what?
Aqueduct
Cerebral.
Sylvius.
Aqueduct.
Yes, aqueduct of Sylvius. Okay, so this area just behind this one, it is the tectum. It we call tectum. This one. This is the tectum area, tectal area. So in between this area, from toward this one, this area. So what we call it?
Tegmentum. Tegmentum. sir.
Tegmentum. Excellent. So this area, the middle area, this is called the tegmentum. So what about this one?
Substantia nigra.
Excellent. Substantia nigra. Substantia nigra, anterior to substantia nigra. This is the
Crus-
part that we call
Crus cerebri, sir.
Crus cerebri. Excellent. Cerebri. Okay, so there are three parts. This is crus cerebri, the area in between the substantia nigra and the aqueduct of Salvius. The middle area is tegmentum. Just posterior to this one is the tactile plate. Okay, it's clear?
Yes, sir.
It is clear? So like the all other, you can say, the brainstem interior surface, it also has the midbrain, the gray matter and the white matter. Gray matter contains the nuclei and the white matter contains the tracts, descending tracts. So let's discuss the nuclei first. So this is the area I have told you that the tectum that's posterior to the Salvius of aqueduct. In between the Salvius of aqueduct and substantia nigra, this is the area of tegmentum, and this one cerebral peduncle or crus cerebri. Okay, let's discuss the nuclei of the gray matter. So this is the first nucleus that we can see. This is the red nucleus. Okay, red nucleus is present in the midbrain. Okay. Yes, it gives the rubrospinal tract. You are right, Dr. Mustafa. It has a great importance. Why it's great importance? Actually, it is rubrospinal tract. Actually, it's not an isolated tract. It is a part of the corticopontine tract. Yesterday we have discussed what happens actually. The corticopontine tracts from cortex to pontine nuclei. In yesterday class, we have discussed that trapezoid body is formed just posterior to trapezoid body. There is a pontine nuclei. And the pontine nuclei is very important because it gives the origin and have the importance and association of the corticopontine tract. So what happens? Corticopontine tracts from the higher contracts. Look at the above picture. From the higher cortex, there is a corticopontine tract. Then from the pons, they go towards they travels towards the cerebellum, and this tract is called the pontocerebral tract. Then from the cerebellum, they will go back to the red nucleus. Then it's called the cerebello. Then from the red nucleus, it will go downward to the spinal cord. Now it's called the rubrospinal tract. So it has a lot of good association this on this tract, the other corticopontine tract. So the first nucleus is the red nucleus that isolate when you talk about it gives the rubrospinal tract, but actually it is the part of the corticopontine tract. Okay. Second one, when we go posteriorly, the area of superior colliculus, we have the level of the superior colliculus and inferior colliculus. Just before to this one, superior colliculus, we have also this area that is called the substantia nigra. Substantia nigra has two parts. Okay. Substantia nigra has two parts. This darker part, which have this granules, you can see the anterior part, this is darker part. Yes, can you appreciate? And the posterior part, this is less darker, little bit grayish color and smooth one. It has two parts. What the name of these two parts? Substantia nigra. Yes, please. Substantia nigra. Yes, Dr. Mustafa, you want to say something?
No, sir.
Substantia nigra has two parts. This darker part that is more important, it is called the substantia nigra pars compacta. It is called pars compacta. And the posterior part that is less darker and little bit grayish, light grayish there, that is called the substantia nigra pars reticularis. Okay, it has two parts, compacta and reticularis. Most important is the pars compacta. Okay, what is the importance of this substantia nigra? Yes, please. Yes. What is the importance of substantia nigra?
So Parkinson's disease में dopamine.
Dopamine. Neurotransmitter dopamine is there. So how it works? It actually works with the association of basal ganglia. How it works with the basal ganglia? Look at her. There is another important, beautiful relationship of this one. Actually, what happens when there is a corticospinal tract, they send the information for any kind of a movement, any kind of a response. Actually, this information do not go, this information from corticospinal, when it will go downward, it's not go directly to the spinal cord. When it go downward at the level of basal ganglia, this information will go to the basal ganglia. Basal ganglia will process this information and module this information and modify this information according to the information that has been given from the corticospinal tract. Then this again information will send back to the corticospinal tract at the higher motor cortex. Then will go this information downward. Okay, got it? Corticospinal tract take the response, efferent pathway at the level of basal ganglia. This information will go to the basal ganglia. Basal ganglia will process and modify this information according to the response, then send back this information to the higher motor cortex. Then it will descend downward as the help of the corticospinal tract. Then what information it goes? It is start the movement. It is stop the movement, modulate the movement. So what we see in the Parkinson, these are things we see in Parkinson. We cannot start the movement. We cannot stop the movement. We cannot modulate the movement. This is the basics of Parkinson actually, and this is the basic of the function of substantia nigra. Got it? Any question? No?
No, sir.
Okay. So this is the substantia nigra, another nuclei. Then we see at the level of the superior colliculus. Superior colliculus, we have another nuclei, that is the nucleus of oculomotor nerve. Oculomotor nerve actually give two nuclei. One is the pure nucleus of the oculomotor nerve, and second is the accessory nucleus of the oculomotor nerve. Okay, these are two nuclei. There is a small one just posterior behind to the main nucleus. So what happens, this oculomotor nerve, it has the importance in the third nerve. That is has the importance in the, what is the importance of oculomotor nerve?
Controlling the extraocular muscles.
Extraocular muscles, not in the ocular pathway, Dr. Mustafa. Yes, you're right. Extraocular muscles. It innervates the extraocular muscle.
The
Okay.
recording is stopped.
Why it is stopped?
It was being mentioned over here. Record. Okay.
Okay, now it's progress. Okay.
Assalamualaikum.
So-
I'm so sorry, I lost my internet connection for a brief moment. So would you be, was it continued or did it stop?
No, we are continuing it.
Okay, okay.
Superior nucleus. Superior colliculus, that's oculomotor. It has two nuclei, main and the accessory. So extraocular muscle. And what about this? That is the accessory nucleus, the oculomotor. It gives the parasympathetic supply. Okay, parasympathetic supply of the third nerve that is given by from the posterior accessory nucleus, the oculomotor nerve. So this is the another nuclei, the gray matter, superior colliculus level. So when we see another one, when we see that the level of inferior colliculus, we have another nuclei, that is the fourth nerve, the trochlear nerve. The trochlear nerve, again, it is originating from the posterior surface, but it will come to the anterior surface. Then it will innervate the superior oblique muscle of the extraocular movements. Okay, so this is the level of the inferior colliculus muscle. Got it? Yes, please. Clear?
Yes, sir.
Yes, sir.
Clear.
Yes. Okay. At the level of this one, we have last nucleus. That is the mesencephalic nucleus of the nerve. Trigeminal nerve gives the four nuclei actually. One is the mesencephalic nucleus of the trigeminal nerve. This one. Principal nucleus of the trigeminal nerve. Spinal nucleus of the trigeminal nerve. Motor nucleus of the trigeminal nerve. So what happens about the mesencephalic nucleus or trigeminal nerve or other nuclei? They are not present in the midbrain. They are most likely present in the at the level of bones. But what happens? The mesencephalic nucleus, that this one, it is some portion is present in the midbrain. These nuclei give separate information, not all information. Mesencephalic nucleus, It gives the sensory information of muscle of mastication, this mesencephalic nucleus. What about the principal nucleus or trigeminal nerve? It gives the information of touch and pressure and proprioception. What about spinal nucleus of the trigeminal? It gives the information of the muscle of mastication at the area of the trigeminal nerve, sensory information related to the pen. And what about the motor nucleus of trigeminal nerve? Yes, please. Yes. Motor function of the muscle of mastication. Got it? Muscle of mastications, the motor function is driven by the motor nucleus or trigeminal. So mesencephalic, it gives information about the sensory information of muscle of mastication. Principal nucleus, it gives pressure and touch. Spinal nucleus, it gives pain. And motor nucleus of the trigeminal nerve, it gives the motor function of, you can say, the trigeminal nerve. So this is the nucleus that is here placed. This one, it is the mesencephalic nucleus of trigeminal of inferior colliculus. There are second, that is the nucleus of cochlear nerve. It is clear up to here. It's clear.
Yes, sir.
Yes,
Yes,
sir.
So we have completed the gray matter nuclei. Okay. Now come to the white matter tracts. It's quite easy, and you people know very well that what are tracts. I will not go into detail. You will tell me that what tracts will be there. Okay. So these are all the tracts. We have completed the spinal cord, and yesterday I briefly told you that how tracts come and then come to the medulla oblongata and then pons and the pons and the midbrain. Till that yesterday pons, we have discussed all these tracts. We have discussed medial lemniscus, we have discussed spinal lemniscus. Look at here, this bluish, these are the ascending tracts, and the red one, these are the descending tracts. In the important one thing that is important, just laterally they are this ascending tracts are laterally placed in the tegmentum, and medially placed the tracts in the tegmentum are the motor descending tracts. What about the crus cerebri? All tracts, these are the descending tracts. There's no any ascending tract in the crus cerebri. So this is the red nucleus. Let's see the ascending tracts. Look at here. This is the medial lemniscus. You know very well. I will not go into detail how medius lemniscus is formed. This is spinous lemniscus, and this is yesterday we have discussed. This is lateral lemniscus. How the lateral lemniscus is formed? How the lateral lemniscus is formed? Yes, please. Yes. Do you remember that how lateral lemniscus is formed?
So spinothalamic tracts.
Spinothalamic tract will not form the lemniscus. What about then spinal lemniscus?
From the cochlear nucleus, from the cochlear and auditory fibers. Cochlear and auditory fibers.
Cochlear fibers. The cochlear fibers. Cochlear nerve will go to the pons. At the site of the pons, what happens? Some fibers will cross contralaterally. They form the trapezoid body, and some fibers will go ipsilateral upward. That form the lateral lemniscus. Then from pons through midbrain, and then from midbrain to the superior temporal gyrus at the area of auditory cortex. So here the lateral lemniscus is found by the cochlear nerve. Okay. So medial lemniscus, and this is the spinal lemniscus, and then the trigeminal lemniscus. Let's see one by one. So what this is, what this tract is, just tell me. It is which lemniscus? Complete picture from spinal cord to midbrain, from till the cortex. You can memorize it. You can recognize it. You can review it very easily. That how these tracts are coming from the spinal cord to the cortex. So which lemniscus is this one? Just tell me.
Medial lemniscus.
Medial lemniscus. How it is found? With the help of internal arcuate fiber. Yes.
Dorsal columnar.
Yes. Okay. So internal arcuate fibers. This is the medial lemniscus. So which lemniscus is this one?
Spinal lemniscus.
Spinal
Lateral
lemniscus.
spinal.
How spinous lemniscus is formed?
Lateral spinothalamic tract.
Anterior and lateral spinothalamic tract. Excellent. Okay, these are same lemniscus and tracts which are coming from the spinal cord to the medulla oblongata to the pons to the midbrain. There is no need to be confused in these tracts. Okay, just there is a difference of some nuclei, but more likely the tracts are same. So this is spinal lemniscus. This one medial, the medial lemniscus. This is the spinal lemniscus. So what about this one?
Trigeminal lemniscus.
Trigeminal lemniscus, same tract of that one, that is we have seen that in the bones. So this is the trigeminal lemniscus. So these are the tracts, trigeminal lemniscus, and this one here we have discussed that this is a lateral lemniscus. Now come to the descending tracts. This is the reticular formation that gives to the reticulospinal tract, and this is the tectospinal tract. I will give little bit brief review of tectospinal tract, that how it works actually. So what happens when this is the optic apparatus, you can see easily optic nerve. There are two portions, temporal and the nasal. They will decussate, they form the optic chiasm, that posteriorly there's optic tract, then lateral geniculate body, and these are the optic radiations. Okay, clear? So what happens actually till that lateral geniculate body, some optic tract will go to the lateral geniculate body, and most of them they will go to the optic radiations, but some fibers will go to the midbrain at the level of superior colliculus. Look at here. Okay, can you see?
Yes, sir.
At the level of hair. Okay, some fibers from lateral geniculate body, it will go to the superior colliculus. From the superior colliculus, the tract will come down and they form the tectospinal tract. That's why this tract is helpful while the conjugate moving objects, conjugate movements in the moving objects are there. So it will control the conjugate movements of the eye with the help of head and neck muscles in this way. So got it? Any confusion? No?
No, sir.
It is clear, Dr. Mustafa? I think not
Yes, sir.
clear.
Yes, sir.
So all fibers, most of the fibers, they will follow lateral geniculate body and optic radiation, but some fibers will go to the superior colliculus in the midbrain, and from there they will give the tract that is called the tectospinal tract. Tecto means the tectum or the tectal plate, and spinal means the descending to the spinal cord. Okay, so these fibers have been done. So this is the tectospinal. This is the reticulospinal. This is the vestibulospinal, and this is the rubrospinal tract. Okay. So
Yes.
what about these tracts now? Now come to the crus cerebri tract. There are three important tracts only that are very important. Most of the tracts, that is the mid one, that is the corticospinal tract. Okay. This is the corticospinal tract. Okay. I'm not going to detail of this one. Just actually the corticospinal tract, just posterior medial and posterior lateral to this one corticospinal tract, there is a corticonuclear tract. Okay, most medial tract in the crus cerebri is the corticopontine tract. We have discussed previously in detail. Corticopontine tracts, it is not a single tract. It is the tracts related to the separate hemisphere lobe. Like some fibers, when they are coming from the frontal lobe to the pons, we call it the frontopontine. If their fibers are coming from the temporopontine, occipitopontine, paritopontine. Okay, so this is the corticopontine tract. Okay, and what about this one? What about this one? Forget it. So let's see. So what about this one? These are all the tracts. Medial longitudinal fasciculus, that is the medial longitudinal fasciculus, this one. So we have completed all the tracts. These all tracts: lateral lemniscus, medial lemniscus, spinal lemniscus, and trigeminal lemniscus. And this is the red nucleus. This one, the rubrospinal tract, that is the cerebral rubular tract, this one. And this one is the medial, this is the reticular formation, and this is the medial longitudinal fasciculus, sorry. So this is the tectospinal tract. With the help of superior colliculus, it comes, and this is the nucleus of fourth nerve. This is the nucleus of third nerve. This is the reticular formation. This is inferior colliculus area. So these are the tracts. So you can see the frontopontine are the corticopontine tracts actually, but it has been divided. The frontopontine tracts, occipito-parieto, temporopontine tracts. This is the corticospinal tract. These two, these are the that is called the nucleospinal tract. Okay, got it? Surgical safe corridor. Just 1 minute I will spend on this one, then I will finish this one. It's very easy because we should know. Then if we know the landmarks, anterior surface, in the anterior surface we have two areas. This is peduncle and this is the area that is called the sulcus. This is sulcus, that is the medial sulcus, just medial to. When we are going through this approach, anterior approach, we can follow this sulcus area. Okay, anterior medial zone, this sulcus bilaterally we can follow this one. Okay, and some says that we have to say the anterior lateral area, but it is controversial. Okay, this is again the area that is at the level of you can see the cerebral of aqueduct, pelvis of aqueduct, and the midline. You can see this is the anterior medial zone, same, that is the transverse section that has been shown here, this area. When we say posteriorly we have a lot of approaches. We can divide in this one. This is superior colliculus, this is inferior colliculus. Superior to the inferior colliculus, we can give transverse section, this area. We can approach this level. Okay, then this level, this is inferior to inferior colliculus, this is superior to inferior colliculus, and that's superior to the superior colliculus. Okay, then another area is here. Look at here, this is peduncle, that's a lateral medial zone. This one, look at here, that's inferior to the inferior brachium. This is the inferior brachium. Okay, look at here, this is superior colliculus, superior brachium, this is inferior brachium, thus inferior to the inferior brachium, and in between the cerebral peduncle we can give lateral incision to this one. When we are going laterally with the help of this one, lateromedial zone sulcus is this one. Okay, so this is about some 3 to 4 surgical entry zones and corridors we can enter into the midbrain. Got it? Any question up to here? Yes, please. Any question? No question, then should I ask the question?
Maybe you can try that so that they end up saying something.
Can I ask one question? Dr. Yusra, yeah, Assalamu alaikum. Yes, I wanted to ask that we have discussed the safe entry zone. Can you please also mention what will be the like approaches? What will we use for the midbrain? Like, is it going to be the same that we have previously discussed, like transpetrosal or?
Okay, thank you, Dr. Yusra. Yes, most of the approaches, they are same. Some of the previous approaches that we have discussed previously, we can approach with the help of that one. Like the transpetrosal approach, we can approach with the, if we are doing anterior petrosectomy and moving upward till that the third and fourth nerve, when we discussed in the transpetrosal approach, we have seen that at the level of the corridor that is found supratrochlear corridor and supraoculometer corridor, there are two triangles. When we'll approach these triangles, we can approach the midbrain with the help of transpetrosal approach. But special approaches separately we didn't discuss yet. Far lateral approach, we can approach far laterally. If we are going just above to this one, we are seeing the lateral lesions at the level of midbrain. The lateral lesion placed, we can approach with the help of far lateral. Okay, what other approach? We can go to nasal transsphenoidally. There's a good one when we are assessing the midbrain. We can approach there. We can go endoscopically with the help of endoscopic third ventriculostomy. We can go with the help of supracerebral infratentorial approach that we didn't discuss. Later on, we will discuss this one. We can help with the orbitozygomatic approach with the help of orbitozygomatic, both open and endoscopic. We can approach the midbrain. So these are different approaches. Out of these two approaches we have discussed, but supracerebral infratentorial, transnasal approach, and the orbitozygomatic approach, endoscopic third ventriculostomy or endoscopic approach, we didn't discuss. Inshallah, one by one we'll discuss in detail these are approaches, then it will be easy for you to recall it. Okay.
Thank you, sir. Thank you so much.
Anyone else? No? No question? Then it's for you. Then who will teach us the brainstem in the next session, in my session? Anyone who will teach us the brainstem? Yes, no?
सर जिसका नाम लें
जिसका नाम लूं? आपने उर्दू में बात करके ना महदूद कर दिया है। उर्दू में बात
Use
कर
combined approach.
Okay. So any volunteer? Then okay. So if no, then I will be very happy then if anyone who one day we will select that we will discuss again some anatomy in brief, then approaches, then it will be good for you because the brainstem is very tricky and very difficult. I know. So select one day for you, then anyone from you or two from you, that one will be the medulla oblongata, pons and midbrain. Then we will discuss the surgical corridors, approaches, and in this way it will be helpful for you to understand all the brainstem. Okay.
Okay, sir.
Thank you. Thank you so much. Thank you, everyone. In this way, we have completed the brainstem and most of the surgical approaches. If some approaches are remaining, so we will complete it in the next sessions, inshallah.
Thank you
Dr.
so
Kamal.
much. Thank you, Dr. Itzaz, for taking out so much time over the past few sessions. And we all understand that teaching brainstem anatomy and then surgical approaches, it's a really, really difficult job. I would not envy your sessions at all. They were really difficult topics. And I'm sure a lot of them did get at least some of them. And if they didn't, then they can always go back and review the recordings. All of them are there. From tomorrow, we start the rapid clinical review, and Dr. Itzaz will probably 2 sessions. We will see if we can get him for a Sunday session as well, but that's not on cards right now. It's 2 days. He would be taking 4 days. I would be taking, so there will be 6 sessions a week. Since a lot of you are appearing in exit exams in the next 2 months, and we wanted to facilitate as much as we can. So this is a wrap for this session. If there's any feedback, any questions, any comments, you can always leave on the group. We will try to respond as best as we can. Thank you so much. This is a wrap.
Thank you. Thank you so much, everyone. Thank you, Dr. Kamal.